Hello everyone and welcome back. My name is Michelle and today we would be covering a crash course on shoulder dislocations. Here is a basic breakdown of today's contents. I will first be starting off with the anterior shoulder dislocation as they are much more prevalent. They comprise of more than 90% of all shoulder dislocation cases, whereas posterior shoulder dislocations account for about 5% of these cases. The mechanism of injury of the anterior shoulder dislocation is either an abducted arm, which is externally rotated or hyperextended, or a blow to the posterior shoulder. This can occur either involuntarily or voluntarily. In the involuntary setting, these are usually traumatic, whereas in the voluntary setting, they are usually atraumatic. The clinical features of an anterior shoulder dislocation include pain, arm is held slightly abducted and externally rotated. There's a squared off shoulder, positive apprehension test, positive relocation test, and a positive sulcus test. It would also be important to examine the axillary nerve and musculocutaneous nerve, as well as its blood supply. On radiography, we can do an axillary view, which would show an anterior humeral head, a transscapular view, also known as a Y view, which would show the humeral head anterior to the Mercedes-Benz sign, and then an AP view, we would show a subcoracoid lie of the humeral head. There can sometimes also be a heel sash lesion or a Bankart lesion. The treatment of anterior shoulder dislocations, we would pursue a closed reduction with IV sedation and muscle relaxation. And then traction, counter-traction reduction, which includes either the Stinson, Hippocratic method, or Cunningham's method. A post-reduction X-ray is always essential, and assessment of the post-reduction neurovascular system. Sling the shoulder for 3 weeks, followed by shoulder rehabilitation. Moving on to the posterior shoulder dislocations. The mechanism of injury is an adducted or internally rotated flexed arm, or it can also be due to a fall on outstretched hand injury. These usually occur from the 3 E's, including epileptic seizure, ETOH, which is alcohol intoxication, and then electrocution. The mechanism of injury could also be a blow to the anterior shoulder. Clinical features of posterior shoulder dislocation include pain. The arm is held in adduction and internal rotation. There's inability to externally rotate the arm, anterior shoulder flattening, prominent coracoid, palpable mass posterior to the shoulder, and a positive posterior apprehension or jerk test. The neurovascular assessment here would be the same as that of the anterior dislocation. On radiography, the humeral head would be posterior, the humeral head posterior to the center of the Mercedes-Benz sign, a vacant glenoid sign, and positive rim sign. Sometimes you could also find a light bulb sign, reverse heel sashes lesion, or a reverse bony Bankart lesion. The treatment of a posterior shoulder dislocation is largely similar to that of the anterior shoulder dislocations, which includes a closed reduction with sedation and muscle relaxation, inferior traction on the flexed elbow with pressure on the back of the humeral head, post-reduction X-rays as per usual, and assess the post-reduction neurovascular status, sling for 3 weeks followed by shoulder rehabilitation. The prognosis or recurrence rate depends on the age of the first dislocation. If the patient is less than 20 years old, the recurrence rate is 65 to 95%. Between 20 to 40 years old, it is between 60 to 70%, and greater than 40 years old, the recurrence rate is 2 to 4%. Specific complications associated with shoulder dislocations include rotator cuff, capsular or labral tears. These can also be known as the Bankart or slap lesions. There could be shoulder stiffness, injury to the axillary nerve, artery or brachial plexus, and recurrent or unreduced dislocation, which is by far the most common complication. And that brings us to the end of today's crash course. Please leave your thoughts in the comments below, and if I missed any important, please also remind me of such in the comments. I hope this video really helped, and I will see you next time. Good luck for examinations.